This is Robert Weinstock, MD, alongside Carolyn Watson, MD, and we are going to be talking about bimanual cataract surgery. And this session is sponsored by MST Instrumentation. This episode is on diamond blade incisions, capsulorhexis, and hydrodissection. This is the diamond blade we use every day for our paired incisions. It's a 1.4 to 1.6 millimeter trapezoidal diamond blade that is used for our corneal wounds or near clear corneal wounds. We use the blade for both our paracentesis and our main wound is the same exact size. You can see that it has a covering, so it's usually handed to us open and we return it closed so we don't stab our assistants as we're passing off instrumentation. That's what it looks like when it's closed and it comes straight out. These diamond blades, if they're taken care of well, can last literally a lifetime. But they must be cleaned properly and taken care of properly. Here's a high magnification view of the lens and what it looks like, that trapezoidal shape with the front and the back with a beveling on the top. You can see the first shoulders are 1.4 millimeters and the second set of shoulders are 1.6 millimeters in width, and that's the perfect size for bimanual, my 19 gauge instrumentation. This is the MST Microcapsulorhexis forceps 23 gauge Cybele capsulorhexis forceps. This one happens to have a little measuring tool on the arm of it, so you can use it to measure size of the capsulotomy or the size of the pupil. They come in both a polished marker like this or just plain titanium with no guides or no markers on it. These are slightly sharp with some teeth on it to grab it, as you can see from this high magnification photo. Again, they're slightly delicate. If these are damaged, you can get replacement tips for the handle that it comes on in this Microcapsulorhexis Duet handpiece set. This is a Maimonides forceps. It's on all our trays. It's used to stabilize the eye, provide counter traction when we're making our primary wounds, and is very gentle on the eyes to avoid subconjunctival hemorrhage. You can see how we place the Maimonides forceps right at the limbus as to avoid a hemorrhage, and we put it directly across from where we're making our incision. You notice we open the forceps up to create 2 points of excision instead of just one, and that avoids cyclotorsion, spin, or torquing of the eye as you're making your incision, and you're driving your diamond blade incision directly across into the other instruments, which is a very stable way to make the diamond blade incisions. You can see the two incisions, the pair, are approximately 45 degrees apart. As we operate temporally, this creates a very comfortable operating position for the hands and the two different instrumentations that are needed for bimanual microincisional cataract surgery. These are very small incisions, and a normal Utrata forceps will not fit through this wound, so we have to use this Microcapsulorhexis forceps to create the capsulotomy. And you can see you can puncture and grab the capsule all in one maneuver, so you don't have to switch instrumentation. So it's a very efficient way of nicking the capsule and starting the capsulorhexis and completing it all with the same instrument. We usually are able to do it with just 2 or 3 grasps and making a nice capsulotomy approximately 5 to 6 millimeters in size. With the smaller wounds, we just use a little bit of hydrodissection because you don't need much, and they're small wounds. You don't want to overinflate the eye and cause too much pressure. Here's just another example how the instrument, the Maimonides, is placed across, and the diamond is used to drive directly at it in a single planar incision, a straight stab incision, because it's much like a paracentesis, straight in, straight out, mostly at the plane of the iris, maybe just a little bit down and in. But we do not need to make beveled incisions or stepped incisions or anything complicated when we're working through such small incisions. They seal very nicely after the surgery, and there's no need to get too complicated in that process. So you can see again, we initiate the capsulotomy with the tip of the Microcapsulorhexis forceps, a single grasp, go back, re-grasp close to the tear, bring it around. There's a little bit of oar locking as you learn this, and you have to learn to rotate your wrist to float in that wound, because there's not as much excursion within the wound that's available when you have a larger wound. So very small, quick learning curve. Again, hydrodissection, and easily spins a little bit to get the nucleus mobile. And once again, paired incisions, And you can see that we inflate the eye with viscoelastic, we use Amvisc, and this is how advanced the capsulorhexis can be with this type of instrumentation. Sometimes we're actually able to grab it once, completely around to the inferior area, grab it again, and complete it across the top in just 2 grabs. So a little bit more of an advanced maneuver on the capsulotomy, but we're able to do that repetitively with this instrumentation. Again, stabilizing the eye, no subconjunctival hemorrhage right at the limbus, directly across from each other, a paired incisions 45 degrees apart, quick little inflation of viscoelastic, removing of the capsulotomy. This is a femtosecond laser treated eye. We want to make sure there's no tags and adhesions. We don't pull the capsulotomy out because it gets hung up in the wound. Little hydrodissection and rotation, and we are ready to go. So in summary, instrument list required for these steps: the dual bevel trapezoidal diamond knife, the Maimonides corneal forceps, Colibri style 45 degrees, the 23 gauge microcapsulorhexis forceps, and a 27 gauge cannula for hydrodissection. And this concludes this segment of our tutorial on cataract surgery with bimanual instrumentation. Again, this is Dr. Rob Weinstock and Caroline Watson, MD, and this has been sponsored by Microsurgical Technologies. Thank you.